The next session is quite interesting. We have so many exciting advances in cardiology, but the role of the surgeon remains paramount still, and there are many places where we have no alternative but to have a good surgeon on board. So it's an interesting concept Dr. Satyavan Sharma sir has envisaged it. We will have a panel discussion with the surgeons, wherein there are no presentations as such, but it's going to be a free-flowing discussion on various topics in cardiac surgery. So I invite Dr. Satyavan Sharma sir will be the moderator, and I invite Dr. Arun Mehra, Dr. Sanjeev Vichare, Dr. Sandeep Verma, and one surgeon who has been in this conference right from the first lecture yesterday. He has been attending as sincerely and attentively as any cardiologist. So Dr. Jayant Khandekar sir, HOD CVTS Science, please, he is the fourth panelist. Thanks.
Good afternoon, everybody. And at the outset, I will welcome all my colleagues who have been very kind and have agreed for this interactive session. Welcome Arun, Sanjeev, Sandeep, and Dr. Jain. Actually, the format will be that I have interacted with some of them earlier and have made some questions, and we'll also have some time that audience can ask them the questions. So I'll begin with asking the oldest friend of cardiologist in the panel, Arun. Arun, you have been associated with coronary artery bypass graft surgery for over 3 decades. In fact, you have rescued many of us from surgical emergencies during PCI. And you know, what looks at the end of over 3 decades journey of coronary artery bypass graft surgery, that you have reached a climax, total arterial grafts, minimally invasive, everything has been achieved. So is with excellent long-term outcomes. So do you think it is end of the road for coronary artery bypass graft surgery, or there are some advances which we are not picking up in Mumbai? When we go abroad, we hear of some blah, 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 blah. So I thought I will have your views.
At the outset, thank you very much for inviting us to share our experience of cardiac surgery. I will try to answer your first question by a case that was in fact one of the first coronary artery bypass graftings done in India. In 1984, John Wright came to Jaslok Hospital and he did 8 cases. This patient was then 44 years old. He had had a myocardial infarction and he was one of those 8 patients operated, and he was a survivor. Obviously, these were vein grafts at that time. In 2006, he presented to me for a redo surgery, and I did a redo surgery on him in 2006. So this 44-year-old was now 66 years old, and he followed up with me till at least 2021 when he became 81 years old, and he had a good outcome from coronary artery bypass grafting. So this gentleman had coronary artery disease. He had 2 admissions of 7 days each in his entire lifetime, and we could tackle his coronary artery disease and give him a good active lifestyle. So that is the stage where coronary artery bypass grafting has reached. Now, whether we call it end of the road or whether we call it that we have achieved, we have conquered coronary artery disease is a matter of perspective. But but I understand your question. The question is, what next? So, incidentally, we are 2023. We celebrated 25 years of beating heart surgery. The first beating heart surgery in Mumbai was done in Jaslok Hospital, 28th May 1998. We operated 2 patients, and my team was involved in it, and we have finished 25 years of beating heart surgery. So beating heart surgery has definitely been an advance. It has brought down the expenses. It has made it very, very acceptable even in smaller centers all over the country, and that certainly has proved to be a major advance.
Actually,
Uh,
what I was trying to sort of know from you is a lot of things have been perfected, good long-term results, we all know it. Is there any scope of robotic surgery, endoscopic surgery, some such advances which we don't hear that much in Mumbai as we hear when we travel abroad?
Yes, I was just about to come to that. The next advance from beating heart surgery was going to be with cameras where the surgeon, um, to the surgeon, the heart appears still. The loops that the surgeons wear, they work at such a high speed that as far as the surgeon is concerned, to him the heart appears still, and then beating heart surgery is much, much easier. Having said that, in 90% of the centers, even in the USA, today the standard of care surgery is one mammary and vein grafts. And that is what is the standard of care across the board, apart from 3 or 4 centers in the USA.
So let me just poke you a little bit more. Now, you know, the percutaneous coronary interventions have advanced so much. I don't think there is any area which the cardiologist cannot do. X, Y, Z case, everything can be done. So what do you look at the future of CABG a decade later? What will be the type of cases you will be doing? What you will be doing?
I will poke back and on this, and this was just something that Dr. Sonamne was whispering in my ear, and he was telling me that be ready for explanting of tower. There are so many towers that are going to require explanting, and the explanting is going to require Bental's procedure. So, so this is just a naughty poke back.
So you will be giving up coronary artery bypass graft surgery and taking another. Okay, I'll come back to you, Arun.
So if you allow, I will continue what Dr. Mehra said.
Sure, please.
Because as he rightly said, number one, you said that cardiologists are doing everything, multiple vessel angioplasties, and of course, valve has been taken, tower has been in replacing almost 7. But as he rightly said, I had an opportunity to talk to Dr. Bapat, who is a colleague of mine from KEM. And he said taking out an tower valve is not an easy stuff. Like we take out a biological valve and replace the aortic valve second time or maybe even a third time. That netinol, the whole thing just gets embedded, and it, as he rightly said, requires almost ascending aortic replacement. So it's going to be a tough challenge in the future.
Thank you. I'll now talk a little bit to Sanjeev. Sanjeev is a little different area which I wanted to talk to you, and this was about the pulmonary thromboendarterectomy. You know, this is a thromboembolic pulmonary hypertension is quite common, but what we see is that in city of Mumbai, this surgery has not become popular. Now, I was wondering, is it the lack of awareness amongst the cardiologists that this surgery can be done? Is it that we don't investigate the patients properly? Or is it the lack of enthusiasm on part of the cardiac surgeons that this area is not as developed? I'm not telling it's not there, it's there, but possibly the awareness is not that much there. So I wanted you to enlighten us.
Yeah, thank you very much for the invitation. And it will be a little elaborate answer. If you look at the incidence of CTEP, that is chronic thromboembolic pulmonary hypertension, it's about say 0.1 to 4% of a patients who get pulmonary embolism. And if you look into that is seen in different studies. So someone can say, okay, 99% patients of pulmonary embolism get treated with the medications. When you talk about the risk of getting pulmonary embolism, there are many factors. Patients with thrombophilia, bedridden, those who have major surgeries or malignancies and connective tissue disorders. So there are many reasons for it. Now, if you see, these patients of pulmonary embolism are essentially treated by the physicians and no disrespect to anybody, and the physicians usually think that anticoagulation is the best treatment and it essentially cures the pulmonary embolism, I mean the sequelae of pulmonary embolism. While to an extent you can say 95 to 98% patients get cured, but 1 or 2% of the patients still don't get cured. So now referral from that place usually can happen to say a cardiologist if patient is not doing well. So we're talking about a very small percentage of the patients. Now yes, the awareness of a treatment modality is not there. Let's be honest about the fact. Now, if a patient, now getting even investigations also sometimes become difficult. And when it comes to investigations and subsequent surgical treatment, now you need to have a CTF team wherein a cardiologist, a surgeon, a pulmonologist and a radiologist, all are involved. And yes, there is little lack of that. Secondly, lack of awareness at a ground level about the treatment modality that's available, because pulmonary embolism, CTF surgery is essentially a curative surgery which replaces the, I would say, the lung transplantation. So awareness is something which is very important, and referral to an appropriate surgeon who is doing it. There are surgeons who are doing it, and I'll tell you honestly, I've been doing it for many years, but last 6 months I've not done even one. So it's not that I'm not skilled to do it, it is a demanding job, but the referrals are not there, and they usually come either from pulmonologists or the cardiologists.
So,
This is what is happening in Mumbai.
one important message which has been always, I've been always thinking, and I thought I'll convey it through my thoughts and thoughts of Sanjeev, is that pulmonary thromboendarterectomy, if done in a proper patient, can be an extremely curative thing. The facilities are available in our city, and I think we should be more vigilant in detecting these cases and giving these patients the option of surgery rather than just thinking. In fact, some of the referrals which I get, the patients have told me that I was told that my clot will disappear and everything will be fine, So I think it's a very important message coming out of this interaction.
So one more thing, can I add? What
Yeah.
Sanju said, the conditions like, chronic patients, cancer patients and things like that. I saw a significant, because I work in a public hospital, Sion Hospital, I saw a significant number of cases going up after COVID. And that is probably because of the, thrombotic conditions they were developed to. As he said, like the number of cases we get is not very much. But during the COVID time, I got a significant number of cases, and we were able to operate it in a public hospital also. Because I was lucky enough to attend a workshop by none other than, can I call it the father of thromboendarterectomy, was Stuart Jamison. And that was done in All India Institute of Medical Sciences. So I attended, and we could really save a lot of patients. But if the RV has taken the toll, right ventricle, then sometimes it becomes really difficult. If you don't have a ECMO facility or backup, then it becomes difficult.
Thank you. One more question to Dr. Vicharya. Whom do you think will be an ideal candidate, and what investigations should be done in these cases before we think that this patient is an appropriate candidate for surgery? CT pulmonary angiogram is done very commonly. Of course, its interpretation also from a surgical point of view is completely different than what it is interpreted for giving anticoagulation. And also, do you think these patients should have a right heart cath or any other investigation, or even a pulmonary angiogram, conventional pulmonary angiogram? I wanted your thoughts on it.
So let's come to the first question, who are the ideal candidates? Now, patients who are say in NYHA class 3 or 4. Second point, the patient should have a radiologically proven pulmonary arterial thrombotic occlusions. I'm talking about thrombotic, not a malignancy. So thrombotic occlusions in spite of appropriate anticoagulation therapy for at least 3 months. Then the next criteria would be someone who has got pulmonary artery, mean pulmonary artery pressure over 25 and the pulmonary vascular resistance say over 3 wood unit would be the ideal candidate, provided there are no multiple comorbidities. So this should be the ideal candidate. So many patients can be offered the treatment. Those who have a thrombotic occlusion and are in an NYHA class with a high pulmonary artery pressure as well as a pulmonary vascular resistance. Now the the answer to your next question as to what are the treatment, what are the investigation modalities. So when a suspicion is there, someone who's got a pulmonary embolism earlier, and there is a suspicion, patient is feeling breathless or something, the first investigation I would suggest is a 2D echo, which is non-invasive, can be done at any place. Of course, the expert needs to do it. So wherein if he says, okay, there is a pulmonary hypertension and right heart is struggling or right ventricle is struggling, then that patient should first go to ventilation perfusion scan. Because ventilation perfusion scan, if it is normal, it essentially rules out pulmonary, CTF, thromboembolic pulmonary hypertension. So ventilation perfusion scan is mandatory and it's a highly sensitive investigation. When it compares with the CTPA, the specificity of a CT pulmonary angiography is very high, no doubt about it, but sensitivity is far less. So once you get a ventilation perfusion scan, you have ruled out CTF by saying the normal ventilation perfusion scan. Then the CTPA will come. You can have a MRI also, but the CTPA is more popular. Once you do that, of course, then you get a lot of blood investigation to find out the cause, etc. You need a lung function test. You also need a sonography, abdominal sonography, to know whether there is any pulmonary hypertension or so clots and even an IVC, etc. And then once it is decided, yes, there is a thrombotic uploading, then you of course need a right heart catheterization. Pulmonary angiography essentially is a gold standard to confirm the diagnosis again. And if necessary, of course, the patient should have even a coronary angiography based on his age, etc. So you're doing investigations to see is the patient suitable candidate for a surgery, or say someone who's got a malignancy which is not operable, but that makes sense going ahead with the operation. So those are the investigations which need to be done. But CTPA is more specific, but the sensitivity is far less. So ventilation perfusion scan is absolutely mandatory in every case to begin with.
Thank you. We move on to the different area now, and I'll ask Sandeep. Sandeep has worked with us in Bombay Hospital for a number of years, still continues to work. Sandeep, want to talk to you about the aortic root procedures. And aortic root procedures are picking up in our country, in our city. What do you tell us some important procedures or some important indications for doing the aortic root procedures?
Thank you. Thank you, sir. Thank you for giving me this opportunity. Yes, aortic root procedures, they are now more commonly done as compared to previous times. And one of the main reason for doing the aortic root procedures is our awareness about aortic patient prosthesis mismatch. So there has been lot of the data available to us. Yes, a patient prosthesis mismatch in aortic position can cause adverse effect in the long-term outcome of patients of aortic stenosis. So the aortic root procedures we commonly do for three main indications in the aortic stenotic lesions, which are the root widening procedures. Traditionally, we have been taught to do root widening procedures in the form of Nicks and Manusians. But nowadays there is a more popular procedure, easier as compared to the traditional Nicks procedure, which is called as Boyang's nowadays. In Boyang's procedure, we can get upsizing of the aortic valve up to 3 or 4 size of the native aortic annulus, and we can reduce the incidence of aortic patient prosthesis mismatch. Other than the stenotic lesions, the aortic root procedures are also done for regurgitant lesions. The most commonly regurgitant lesion aortic root procedure, which everybody is aware about, is the Bentall's operation. Earlier, they were less commonly done because of the complications associated with the surgical techniques, fear of bleeding and all those things. But now these procedures are also become more protocol oriented, and with the availability of more safety agents in the form of BioGlue, bovine pericardium patch, where we can avoid the bleeding complications, better grafts and conduits which are available to us now. Now we can do this Bentall's procedure by using mechanical conduits also, and we can do this Bentall's procedure by using biological conduits also. If suppose biological conduits are needed, we can prepare it on back table and do these operations. So these are the other indications. Other than this typical stenotic and regurgitant lesions, we also do aortic root procedures in some emergency conditions like aortic dissections and aortic infective endocarditis. So these are the most commonly done procedures, and I would say the safety of these procedures in recent time has improved a lot, and they can be done very safely at almost all places where these procedures are done in a particular considerable number.
Thank you, Sandeep. And I will ask you another short question and then we will open for the audience. You know, what I'm seeing a little change in the approach of the surgeons nowadays. And many young patients with aortic regurgitation or aortic stenosis, even at the age of 40 years, 45 years, are being tissue valves. Now, my question is, or my worry is this trend futuristic or frightening? So I want you to sort of, so my concern is it frightening? Maybe you will say it's futuristic. So let's know about that.
That's really interesting. Actually, as far as use of tissue valves is considered, traditionally for aortic diseases or aortic procedures, we have been implanting metallic valves, and metallic valves have stood the test of time. But we all are aware that for metallic valves to work properly, PT-INR and maintenance of anticoagulation is mandatory, and anticoagulation has been in a way Achilles heel of metallic valve prosthesis. Plus, along with this, now the tissue wall technology in last 25 years has improved in such a way that we have more durable tissue valves available. Other than that, the patient's lifestyles and patient choice, that also matters in this case. On top of all these things, better availability of tissue valves, then problems of PT-INR, but there has been a lot of advancement in interventional aortic valve procedures also in the form of TAVI and TAVR. So in today's time, in 2024, when we are talking about surgical treatment of aortic valve surgeries, we should also keep in mind that if we give a durable tissue valve to the patient, avoid problems of anticoagulation, and give them such a valve which can in future act as a mold for TAVI valves, then probably the patient may like to choose it. So this, as far as frightening or futuristic, I think only time will be able to tell.
Okay. Thanks, Sandeep.
Yes.
Now we can ask a couple of questions from the.
Sharma sir, in this, I think we surgeons are guilty of not using aortic homograft valves. So the true answer to this is that we should use the
More.
aortic homograft more and more. It is not that we have not tried. In fact, Sion Hospital, Dr. Chaukar has been trying this for several
Many
years.
years.
But there are several problems associated with this. But the true answer to this question is the availability of homograft valves.
Yes, Gupta
Sir,
sahab.
we had so many talks on congestive heart failure, medical treatment, CRT, still high morbidity and mortality. What is the status of cardiac transplantation in today's era to decrease the morbidity and mortality in congestive heart failure patients?
Actually,
when these medical treatments and CRT and all,
Actually, Dr. Anway Mule was to be here to answer this question, but any one of them can. Yeah, sure. Dr. Kamath, most welcome. Please come.
Hello.
Most welcome.
Hello, good afternoon, sir. I work with Dr. Anvay Mule, sir. My name is Dr. Neeraj Kamath. I work in the Department of Advanced Cardiac Sciences and Heart Transplant. So, rightly said, I think congestive cardiac failure has been surgical management of heart failure has been a very, very neglected entity all over the place. But definitely the results of cardiac transplant are improving. Even though the first cardiac transplant happened in 1967, and P.K. Sen sir was one of the 5th surgeons who did the 6th and 7th heart transplant in KEM Mumbai. But unfortunately, it did not get picked up because of 2 reasons. One was ethics, and second was transplant immunology. I think as cardiac surgeons, technically stitching is not a big job. Stitching within 2 hours is not a big job because we have a 4-hour period which involves the travel time of the donor organ. But in transplant, what is more important is the logistics. How you match, like in arranged marriages, how do you match a donor heart with a recipient heart? And the transplant immunology and the retrieval techniques. All the latest advances in heart failure are happening in two situations. One is retrieval techniques. That is what is we are still doing. We are keeping the donor heart in an ice box. And I have been going to ISHLT. I am one of the members of ISHLT. And what is coming up, we are also tying up with few companies to get an Indian box. But there is one beating heart retrieval. There is one ex vivo box where you can give cold cardioplegia in a still heart. And there is one Paragonix box which tries to keep a temperature of 6 to 8 degrees. So these are these retrieval techniques which are really extending the ischemic time for the heart. From 4 hours, it's going to around 8 to 10 hours. And transplant immunology has been one of the main Achilles heel of the success of cardiac transplants. The median survival of heart transplant was around 7 years, about 15 years back. And today the ISHLT data says the median survival is around 14 years. And the conditional median survival means we do a heart transplant, patient survives for the first 1 year, and after that, the median survival is crossing 15 years. So, and it gives you an excellent quality of life. We have pediatric heart transplants, around 30 which we have done, and around 150 adult heart transplants. The first year mortality rate is around 85 to 90% because in India, the referral is a big problem. We tend to get patients when they are in multi-organ dysfunction.
You can keep your comments. Thank you. We can get few more questions. Yeah, Ashish.
So one of the surgery which is underutilized is probably the surgery for hypertrophic obstructive cardiomyopathy. I think Sanjeev has and
Yes, Sanjeev.
others, if they have
Any other topic which you think you can throw light in the next 4-5 minutes which we have.
What is the ideal patient you would like to operate, and when do you address the mitral valve in the hypertrophic obstructive cardiomyopathy patient?
Yeah, so ideal patient should be one who is symptomatic with dynamic gradients over 50 and at rest gradient across the LVOT over 30, and should have a basal septum hypertrophy, not a apical septum hypertrophy. Now, so these are the patients, and of course the surgical results are marvelous. In fact, even the risk of getting a permanent pacemaker is far low. When it comes to tricuspid valve, majority of the patients, I mean, I have seen quite, which I do, there is usually some abnormal attachment to the septum from a mitral valve. Abnormal attachment to the mitral valve coming from the septum. So you need to disconnect those abnormalities, abnormal chordae, etc. And honestly, I'm telling you, whatever 65 odd surgeries I have done, I have only replaced mitral valve twice. That was my first surgery because I was, of course, newcomer into that. And second was, yes, the patient did have a severe mitral regurgitation because under long-standing Hocum problem, wherein the mitral leaflet was so prolonged that I was not able to repair that. So those are the two. Otherwise, rest all cases I got away without touching the mitral valve.
Thank you. Yeah, Milind.
I wanted just the surgeons to shed some light on minimally invasive, especially bypass surgery, because the problem is that the surgeons who do it swear by it, but very few are doing it. So does it have a role, or do you think it is just overhyped and you should stick to the traditional forms of surgery?
Can I? So, minimally access bypass surgery, yes, it is a reality in today's time. We should pay attention to that modality also. Many times when I talk with my cardiology colleagues and all, they always talk of angioplasty, left main angioplasty, complex angioplasty, and one of the advantages that they always mention for angioplasties is that we do the procedure, next day the patient is walking, and third day or fourth day the patient goes home. So I tell you, similar type of thing can be done in minimally invasive cardiac surgery also. As far as minimally invasive bypass surgery is concerned, it is well established. and it has got a, definitely it has got a learning curve of its own. But once you are comfortable doing it in that way, we can give equally good results. Bleeding related complications, sternotomy related problems of the patient, especially in diabetic patients, morbid patients, all those things get avoided and it can be easily done. One point which I would like to add is that in minimally invasive surgery, the left-sided grafting and those things can be done easily. The the currently available instruments, sometimes they actually cause more pain to the patient related to the thoracotomy, traction, pulse and all those things. So the answer to that is that the picking up of the robotic cardiac surgeries or robotic coronary artery bypass surgeries. In robotic coronary artery bypass surgeries or endoscopic coronary artery bypass surgeries, which we called as TEP, total endoscopic coronary artery bypass surgery, all these complications can be avoided.
Okay.
Patients are pain-free. Sometimes the patients are extubated after the operation, even in the operative room. They come out walking, and maybe like after 24-48 hours, no drain, no other complication, we can send this patient home.
Okay, I think we have reached our time limit. Just a 30-second question to Dr. Jain. Anything about any new thing in the pericardial surgery? Because, you know, that's almost disappearing from the private sector. But I think still must be quite a lot
What
in.
you said is absolutely true, sir. I mean, I don't know, private sector is disappearing. But still, as a part of the public hospital and where we get a lot of patients from lower socio-economic class and who are still having a tuberculosis history, we do get constrictive pericarditis regularly. And unfortunately, pericardiectomy is the answer. There is no way other where we can offer them anything else. But after the surgery, they definitely do a lot much better. That their ascites, pupil edema, everything disappears. Their breathlessness disappears. But it is remaining still a part of it because tuberculosis is still rampant. Even though whatever we try, there nowadays multi-drug resistant COX and things are coming. So constriction is still going to remain with us.
Okay. Lot of thanks to my surgical colleagues for enlightening us in these areas, you know, which we are not that much aware. And many thanks for coming and interacting with us. Thank you.
Thank you very much.